Good morning. My name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for MAVEN Project. Thank you all for joining us today, and our friends at North Shore Health Centers in Indiana for requesting today's session. And it's wonderful to have all of our MAVEN Project clinic partners here today as well. Today, we are going to be learning about ordering and interpreting thyroid tests in children with Dr. Paul Kaplowitz. Dr. Kaplowitz is a professor emeritus of pediatrics at George Washington University School of Medicine and the Health Sciences, and in the Division of Endocrinology at Children's National Hospital in Washington, D.C. Dr. Kaplowitz was on the faculty of the VCU School of Medicine in Richmond, Virginia, and then moved to Washington to become Chief of Endocrinology at Children's Hospital. Dr. Kaplowitz, welcome, and I'll go ahead and turn it over to you.
Hello, everybody, and thank you for joining. I understand you've requested this topic, and I think that thyroid issues, particularly ordering and interpreting thyroid tests, is one of the most common consultations we receive at MAVEN. Anyway, before I start, I'll emphasize that it's accredited to provide CME for physicians, and that none of the individuals who, influence this activity have relevant financial informations in relationships to disclose. So let me start by telling you what I plan to cover today. I'm going to first review when you really should order thyroid tests and perhaps when you shouldn't, to discuss which tests in specific are most helpful, and then to review some cases which highlight difficulties in interpreting abnormal thyroid tests. We will briefly discuss management of hypo and hyperthyroidism and how MAVEN volunteers can help with that. And although we're not going to talk a lot about physiology, I think the talk will provide a lot of practical advice for you. So this is an overview of what the thyroid gland does, and these values for secretion rate are for adults. So adults normally, the thyroid secretes about 100 micrograms of T4, a smaller amount of T3, but then there's also peripheral conversion of T4 into T3. But the interesting thing about thyroid hormones is that they're extensively bound to thyroid binding proteins. So for T4, only 0.03% of what's in the circulation is free and able to get into cells and tissues. For T3, it's 0.3%. And that has an important implications for some of the tests that we do. But important to understand how thyroid feedback regulation works. And we know from years of experience that the hypothalamus and the pituitary gland both monitor both free T4 and free T3, and they increase thyroid hormone secretion to keep TSH normal. So that means that in theory, anytime the TSH is increased, that means that there's primary hypothyroidism, but as we'll explain, it's not always that simple. On the other hand, overactivity of the thyroid will increase T3. So what you see is that you have T4 and T3, and that they go into the target tissues, heart, liver, bone, and central nervous system, but they also feed back to, so if there's too much thyroid hormone being produced, overactive thyroid, even if it's only mildly overactive, the TSH will always be suppressed to a very low level. And we'll see why that's important. So let's discuss test ordering. The biggest problem in this area is that thyroid tests are too often ordered in situations where the chance of a meaningfully abnormal test result is low. And then this sometimes results in problems deciding, well, we've got this borderline abnormal test. Is it really significant? So when should when are thyroid tests most useful? Certainly, you should order a thyroid test in any child with an enlarged thyroid gland, particularly if it's not long-standing. Any signs or symptoms suggestive of hypothyroidism, and that would include, but ideally it should be more than one symptom. But new onset of fatigue, cold intolerance, constipation, dry skin, and acquired growth failure. But to be honest, fatigue itself is not a major symptom. But if you have fatigue and a goiter or fatigue and any of these other symptoms, yes, you definitely should order it. And then there's follow-up of abnormal newborn thyroid screening tests, which I'm sure you've all had some experience with. And then more than one sign or symptom suggesting of hyperthyroidism, and that would include goiter. So hyperactivity is certainly one, unintentional weight loss, unexplained tachycardia, heat intolerance, and even declining school performance, which has in many cases been confused with ADHD. So if you have two of these signs without a goiter or a goiter plus one of these signs, you definitely need to screen. So on the other hand, there are many situations when thyroid testing is low yield. And the one that we encounter most often is obesity. Obesity is not caused by hypothyroidism because even the most severe hypothyroidism causes only a modest 5 to 10 pound weight gain, and it's mostly water and not fat. So unless there's accompanying slowing of linear growth in a patient who's not, at the end of puberty, obesity should not trigger thyroid tests, although, of course, many people do. Mild short stature with a normal growth rate is very unlikely to be a thyroid issue. Failure to thrive, where the main symptom is poor weight gain. History of thyroid disease in a relative, but no sign or symptom in a child is very low yield, as is hyperactivity alone. So what thyroid tests should you order for screening purposes? Well, the most useful test is the TSH, and it has a normal range of about 0.5 to 5, but it can be higher in newborns and infants. And you can order TSH with a total or free T4, or you could order it with a reflex, meaning you'll only get the T4 if the TSH is high or low. The total T4 is fine as a screening test, but it can be affected by high or low binding proteins in patients that don't have a thyroid problem. Now, a free T4 is more accurate than a total T4, but it is somewhat more expensive. So if you're trying to save money and your index of suspicion is low, a total T4 is fine. So free T4 is not affected by high or low levels of thyroid binding protein. One of the problems is that each lab has a somewhat different normal range, but it's usually in the range of 0.9 to 1.6 nanograms per deciliter. So what tests should you not order for screening purposes? High on the list is T3. And it's two reasons. One is that it's not infrequently mildly elevated when the free T4 and the TSH are normal, in which case you would just ignore it. And its main use is confirming a diagnosis of hyperthyroidism. The free T3 is no more helpful than a T3, but it costs more. And then there are thyroid antibodies, particularly thyroid peroxidase. But you really shouldn't, even if you do order antibodies, you shouldn't be ordering anti-thyroglobulin antibodies. And the problem is that they're often mildly elevated in patients who don't have any thyroid problem at all, particularly in females. But they may be useful in children who have mildly elevated TSH, because if the thyroid antibodies are very high, you may need to monitor them more often to see if it's progressing to hypothyroidism. Let's talk about acquired hypothyroidism. It may present with the typical thyroid-related symptoms that we discussed earlier, or it may have no symptoms at all. And the free T4 is typically in the low normal or borderline low range, with a TSH that's moderately elevated in the 10 to 40 range. And painless thyroid enlargement often is the only clue to diagnosis. And, 90+% of cases in children are due to autoimmune thyroiditis. It's autoimmune inflammation. And positive thyroid antibodies are helpful in confirming the diagnosis. So here's a patient I saw both before and after treatment. And what do you notice about this child, other than that she's dressed kind of warmly? It was actually the summer when I saw her. And what you can see is this is after a few months after treatment. So that round, bloated facies is classic for severe hypothyroidism. And this has been going on probably for years. And it really dramatically resolves once treatment is started. And here's another case. This was a girl who the mother brought a picture of what this child looked like a year earlier. And then this was at her first endocrine appointment. So you can see the puffy, bloated face. But that's really only seen in severe hypothyroidism. And as in the mild to moderate cases, most commonly due to autoimmune thyroiditis, you may see a total T4 that's less than 1, with remember normal is about 6 to 12, free T4 less than 0.5, way high TSH, positive antibodies. And the face becomes puffy due to edema, which can result in modest but not severe weight gain. And in cases this severe, growth arrest is common. So if you have a growth chart and in a prepubertal child, the child has been growing normally and then levels off, that's a big clue. And these patients are so lacking in energy that they tend to stay inside and sleep a lot. And what's nice is that you really see dramatic improvement within just a few weeks of starting treatment, as well as, the change in their face. So how do we manage hypothyroidism? Well, the starting doses typically range from 37 to 75 micrograms per day, and that depends on the age of the child and the severity of hyperthyroidism. So you can always have patients managed at a pediatric endocrine center if that's convenient for the family. On the other hand, should you decide to manage the patient yourself, my advice to you is to please wait 1 to 2 months after starting before retesting to give the tests a chance to level off. And let's say, you retest and the free T4 has come back to normal, but the TSH, while better, is still high. That would be a perfect time to consult with a MAVEN volunteer regarding, you can keep the dose the same, or maybe you need to tweak it a little, or maybe you need to back off a little. So here's a thyroid test that you might encounter in your practice. So here's a case where you decide to order thyroid tests on a 5-year-old boy, has been growing along the 5th percentile. His exam is normal. There's no goiter. And you decide to, be thorough and order thyroid tests. And the free T4 is normal, but the TSH is low at 0.25. So Is this child hyperthyroid and does he need to see an endocrinologist, or are additional tests needed? And I will give 30 seconds so that you can enter your responses in the chat. Okay. So the important thing to be aware of is that if you have a normal total or free T4 and the TSH is between 0.1 and 0.5, don't worry about it. Remember what I told you earlier, that even in mild hyperthyroidism, the TSH will be less than 0.1. And, because the free T4 is normal and causes no symptoms, it really doesn't, it's no, there's no treatment needed. And more important, and this is an issue that we often have, is people feel the need, well, I better do it again. But the chances that you've caught hyperthyroidism early and that you need to follow it up are extremely low in my experience. And so no need to confirm. Jill, can you tell me how people responded?
Great. We have two comments. One is, should we recheck in 1 month to confirm? And then somebody writes additional test.
All right. Well, there you go. It's, if you repeat it in a month, you will probably find exactly the same thing and you will not be any wiser about the case. So this is one where you really don't need to worry. So here's another case. You have a 13-year-old who's experiencing more fatigue, but a history and physical exam is normal. This time, the problem is the free T4. It's 0.85, and the TSH is normal. So first question is, are these results likely the cause of her symptoms? Is this a case of primary hypothyroidism? Or maybe this child has secondary or pituitary hypothyroidism, where the free T4 would be low and the TSH is not elevated. And would you do additional tests? So I will wait 30 seconds for people to put their thoughts in the chat. So I see no additional tests needed. Not the cause of her symptoms, no additional tests. Okay. Would do additional testing to rule out anemia? Well, my thought is that if you have worked this patient up for fatigue, you've probably already done a CBC. So, oops. Anyway, so the answer to this question is that, oops. Borderline low free T4 with normal TSH is another common normal variant, which rarely progresses to anything. And in my experience, hypothyroid symptoms do not develop unless the free T4 is significantly low, as in less than 0.7. In theory, this could be secondary or pituitary hypothyroidism. But most cases for pituitary hypothyroidism, there's a history of a CNS tumor, CNS surgery, or CNS radiation. So, once again, if you are uncertain, you're welcome to consult with MAVEN, but there's no need to repeat this test right away. All right, here is another test, and I am positive that you have all seen patients like this. You're doing an obesity workup, and you have a patient who's gained quite a bit of weight, like maybe 40 pounds in the last 2 years, but her height is increasing along the 90th percentile. You find a free T4 of 1.1 and a TSH of 6.5. There's no goiter, and the exam is normal other than the obesity. So does this child have hypothyroidism? And should you refer right away to endocrinology for evaluation and possible treatment? Or is this a patient that you could follow in your office? So I will wait to have people put their okay, so I see somebody said follow in office. I just see 2 responses, follow in office, follow in office. Okay, so nobody would get too upset about this case. So what can we learn about? Oops. Okay. So as I think most of you are aware, there's no rush to have these patients seen by a specialist. And it's been shown that TSH, that obesity itself can result in higher TSH levels. On the average, they're not markedly higher, maybe half a unit, but there are more of these obese patients with TSHs of over 5. Now, if your obese patient with a TSH that's borderline has a goiter, they should probably be referred because they have a greater chance of having thyroid disease and progressing to overt hypothyroidism. For other patients with, normal T4 and those borderline TSHs, I would suggest repeating the free T4 and TSH in somewhere between 6 to 12 months. And if the TSH is greater than 10, which I can tell you is relatively rare in this scenario, then the child could either be seen or, again, you have the option of consulting with MAVEN. But the reason for waiting not a month, as many people are likely to do, but for 6 to 12 months, is if this is hypothyroidism, it's probably very slowly evolving. And by waiting 6 to 12 months as opposed to 1 or 2 months, you give the TSH time to rise significantly if it's going to do that, or even it may come back to normal. Because in nearly all cases, the TSH will either decrease to normal or remain in that borderline range. Now, if the child is obese and you're lucky enough to get weight loss, either with drugs or with, dietary and lifestyle advice, that can lower the TSH in itself. So should one use thyroid antibodies to decide if the child should be treated? And, you can go either way on that. If the antibodies are borderline high, they don't make any difference. But if you have very high antibodies, that's a patient that you're kind of want to monitor more closely. But generally speaking, I don't recommend treating unless the TSH is greater than 10. Okay, let's move to a different scenario. And your state newborn screening lab calls your practice to report that an 8-day-old infant tested at 2 days of age before he went home from the hospital, had a T4 which looks fine, but the TSH is rather high. So these are the options as to what to do next. Either send another spot to the state lab for confirmation. T4 is normal, so maybe it's a lab error. You could tell the parents to call the endocrine office to get an appointment, which, as you well know, could take a while. You could discuss the case by phone with a pediatric endocrinologist, or you could send the child to a commercial lab for T4 and TSH. So let's see what sort of, okay. All right. So we have either send another newborn screening or send to the lab or resend the newborn screening and discuss with an endocrinologist, repeat lab and start therapy, resend newborn screen and discuss with endocrinologist, recheck and talk with endocrine. Okay. So what would I have done in this case? Okay, let's talk about congenital hypothyroidism. It occurs in about 1 in 2 to 4,000 cases. And so I am sure that, most of you who've been in practice for a while has had at least one of these in your practice. So newborn screening programs based on blood spots will either do T4 first and then TSH if the T4 is in the lowest 10%, or they'll do the TSH and possibly T4 right away, and that depends on the state. Congenital hypothyroidism is the most preventable, most common preventable cause of intellectual disability. Early detection and treatment within the first 2 weeks of life is key for preventing developmental delay and loss of IQ points. Most cases are sporadic due to thyroid dysgenesis, means either the thyroid is not there, and those are the most severe cases, or there is thyroid tissue, but it's in the wrong location or ectopic. So early referral is critical, though in some cases, co-management with specialists is possible, particularly if you're at a good distance from your nearest endocrine clinic. And while treatment is clearly needed when the T4 is low and the TSH is high, there are some cases where the T4 is normal and the TSH is borderline and mildly elevated. And cases like that are perfect for consulting with our MAVEN volunteers. But to get back to your answers, one of the things that I would not do in this case is send another newborn screen, because that could take another 5 or 6 days to get the results back. And if you want to get the tests repeated, you send them to a commercial lab and you'll have the results back in a day. And but you would also want to discuss this case with your local endocrinology office, because they will either tell you, we'll see this patient tomorrow, or in 2 or 3 days, or we can't see this patient right away, but why don't you get the patient started on treatment, and then we'll see the patient when we can. So do not send another screen, but get this taken care of right away. Okay, now here is another thyroid case. So you have a 15-year-old girl who complains of rapid heart rate, difficulty sitting still, and failing grades at school. She has lost 20 pounds in the past year and is not dieting. Her thyroid is diffusely enlarged. Her heart rate is 120, and you order some tests, and you get a free T4, 4.8, a T3 that's quite high, and the TSH is very suppressed. So what's the most likely etiology, and are any additional tests needed? And I think the etiology is pretty clear. So I will just move ahead to the next slide. Oh, here is a picture of a couple of girls with hyperthyroidism, and they not only have the goiter, which you can see pretty clearly, but they also have uh, proptosis and exophthalmos. Now, it turns out that only about half of the kids with hyperthyroidism have eye signs. So the absence of, exophthalmos should not dissuade you if you see the goiter and the other symptoms. So this is a classic case of hyperthyroidism due to Graves' disease. The etiology is the production of antibodies which bind to and activate the thyroid cell TSH receptor. Measurement of thyroid stimulating antibiotic immunoglobulins or TSH receptor antibodies will confirm the diagnosis, but that should really not delay your sending the child to the specialist. And the tests are not going to go back to normal right away. So, in doubt, if the diagnosis is in doubt, the endocrinologist will do it right away. Otherwise, they might wait until a follow-up visit. Anyway, about 80% of cases are in females, and that's also true of hypothyroidism. And it's most common during the teenage years, but we do see a fair number of cases in kids less than 10. So this is one of those situations where you don't, I would suggest that you not just tell the patient, call and get an appointment, because if you call and speak to an endocrinologist uh, and you have tests that are really clearly abnormal and the patient is symptomatic, they will usually get this patient seen either the next day, or if it's a Friday, they'll get the patient seen early the next week. So how do we manage Graves' disease? Well, the first line therapy is methimazole, which blocks a key step in thyroid hormone synthesis. So it's not a cure, but it's, puts the brakes on the thyroid gland. And you really should wait at least a month or two before rechecking to give the methimazole a chance. So if you've gotten the patient seen and they're going to be followed up at, the endocrine center, you don't have to worry about this because they'll decide when to recheck. But if you end up managing this patient by yourself, wait at least a month or two to recheck. And dose adjustments can be tricky. For one thing is that the free T4 can drop to normal, but the TSH may remain suppressed for quite a few months. Because dose adjustments can be tricky, most of these cases are managed by specialists. On the other hand, if you choose to manage these patients yourself, a MAVEN volunteers can help you interpret the follow-up tests and suggest adjustment in methimazole. The starting dose of methimazole is usually 10 to 20 milligrams a day. Only 20 to 30% of patients treated medically, well controlled, after 2 years will go into remission. So after 2 years of treatment, the provider, the endocrinologist will usually stop treatment for a while to see if the patient is in remission. And the ones that aren't in remission may need radioiodine ablation or occasionally subtotal thyroidectomy. But there are some patients who, can be managed medically for many years and may do fine and may go into remission after longer than 2 years. Okay, so here is a 12-year-old girl who's screened for thyroid disease because of a positive family history of hypothyroidism. The exam is normal, but and there's no goiter. And her free T4 is normal, but the TSH is 0.03. Thinking that this is a lab error, you repeat the test results and get the same results. And you add a T3, which is at high normal. So my question is this early hyperthyroidism? And what would your next step be? So I'm going to give a little time for you to put your answers in the chat. So the responses I have are continue to monitor, recheck in 6 months. Let's see, anything else? Oh, yes, could be early hyperthyroidism, repeat in 6 months. Okay, well, good. So, okay, so basically what we would call this is subclinical hyperthyroidism. And it's, not the usual, but it's not all that rare either. And some years ago, a colleague and I published a series of 24 cases seen over a 3-year, 4-year period at my hospital. And in most, the TSH eventually normalized. Only a few actually became hyperthyroid and a few became hypothyroid. So you can have a situation where you have an early hyperthyroid phase due to thyroiditis, and then they become hypothyroid over time. So I think given that this is not the typical situation, I think it's, you could certainly suggest that patients be seen by endocrine in 2 to 3 months. And so this is one of those situations where you don't want to retest right away because you're going to get the same results, but you want to wait a few months. And, I know a couple of people suggested 6 months, and that's fine too. So if you want to follow this patient yourself, repeat the tests in 3 to 6 months, but make it clear to the family that if the patient's becoming symptomatic, developing hyperactivity, weight loss, anything like that, they should be seen sooner. But definitely this needs a follow-up because they can become, they may normalize, but the TSH could go way up or way down. I thought I would at least briefly, this is not really a test result per se, but I thought I would at least briefly mention thyroid nodules because I know some of you, are detect these or they're reported on an ultrasound and you don't know what to do. So thyroid nodules. If it is large enough to be seen or palpated on a careful physical exam, that needs evaluation. Because in kids, the chances of a thyroid nodule being malignant, while not high, in the range of 20%, it's a higher rate of malignancy than similar nodules in adults. The bigger the nodule, the greater the chance of finding thyroid cancer on a fine needle biopsy. You could order a thyroid ultrasound to confirm that what you feel is within the thyroid gland and not a lymph node. On the other hand, in many cases, a thyroid ultrasound is done either for a goiter or just as part of a neck exam, and that you find small nodules. And they're usually less than a centimeter in diameter. They're and often less than half a centimeter in diameter. And they're very common and rarely are cancer. So my main advice to you is do not order ultrasounds for a symmetrically enlarged thyroid gland. If the patient ends up seeing endocrine and they order the ultrasound, that's another thing. But um, there is really an over diagnosis of thyroid nodules because ultrasound will pick up nodules that are too small to be worried about. So in summary, try to avoid ordering thyroid tests in situations where the diagnostic yield is very low. The fewer thyroid tests you order, the less time you'll spend figuring out what to do about results which are outside the normal range, but of dubious clinical significance. For children who really need treatment for hypo or hyperthyroidism, the results are rarely borderline. So when is a referral urgent? Moderate to severe symptomatic hypothyroidism. And, the good news is patients usually start to feel better a week or two after starting thyroid replacement. And moderate to severe hyperthyroidism, where the total T4 is usually greater than 15, the free T4 is greater than 2, and the TSH is suppressed. And these patients will again start to feel better. It usually takes a little longer, but after 4 to 6 weeks. Anyway, so that is um, uh, what I have to say, but I am happy to answer questions because I'm sure I have not covered all of the issues that you have encountered.
Dr. Kaplowitz, thank you so much for an excellent presentation. I loved your case studies and incorporating our audience members too. So thank you so much for the attendees for participating in that way. So just wanted to encourage people, if any of you have questions for Dr. Kaplowitz, feel free to put them in the Q&A via the Q&A icon on your Zoom toolbar, or I think we're a small enough group that you can put it in the chat as well. Or if you prefer to raise your hand if you have a specific question or want to review a case that you've seen. So I'll go ahead with a couple of questions that have come in. The first is, what about a TSH order for menstrual irregularities?
Excellent point. I really should have added that to the list of things that are not typically thyroid related. And, I feel a little odd about this because I know many of my colleagues order thyroid tests. I mean, the truth is, if you've got menstrual irregularities, you're going to order a bunch of tests anyway. You're going to order gonadotropins and maybe a testosterone. And so throwing in thyroid tests is not the worst thing you could do, but I have rarely, if ever, seen a case where menstrual irregularities was the primary symptom of a thyroid problem.
Thank you. And the provider adds on, I had a patient several years back, a 13-year-old girl with significant menorrhagia, and her TSH was 173.
Ooh, my question is, did the menorrhagia go away when the thyroid was replaced, or was it could have been an unrelated issue? Can you ask the provider if it
Right, yeah, so
resolved?
I'll give them a minute to pop that in. So, and then there's another question that I'll ask in just a minute. Okay, well, I think I'll move on to the next question, and then when we get some follow-up, I'll let you know. Here we go. Yes. Did not respond to estrogen, improved with thyroxine.
Okay, well, that was a very rare but informative case. Thank you.
Thanks. The next is a patient on methimazole for Graves' disease, and his WBCs were low and neutropenia. At what number should I stop the methimazole?
Ah, well, I would look at the absolute neutrophil count. I would get a little worried if it was below 1,000, and if it's below 500, I would definitely stop it. But, that would be a good one to. I assume that this patient is not being followed by a pediatric endocrinologist, and that you're doing this on your own, but you're welcome to consult. You could either refer the patient for help or consult with a MAVEN volunteer. But yeah, neutropenia and is one of the worrisome side effects. The most severe ones will present with fever. If you have neutropenia and fever, that's a big worry. The other common side effect of methimazole is rash. And sometimes if the rash is mild, you can just give Benadryl and keep them on treatment. But sometimes that's a good reason to say, well, we tried medical therapy and it's time for, radioiodine or more definitive treatment.
Great, thank you so much. One thing that I just wanted to share with everybody is just a reminder that MAVEN Project has a small group of pediatric endocrinologists. They're experts who volunteer their time, and they're really here to help you. And I just wanted to show you again our telehealth platform. So when your clinic is a partner of MAVEN Projects, you all should have accounts if you are a provider. And just a reminder, we have experts in about 69 specialties and subspecialties. So we have adult endocrinology and also pediatric endocrinology. So if you see here, there's Dr. Kaplowitz, who's our speaker today, and that you can submit a consult and that you, on average, get a response within 48 hours. And sometimes our turnaround time is actually less than 24 hours, which is great. And so it can be like a small question, it can be a more complex question, but they're really here to help to support you caring for your patients. So just wanted to remind you about that.
Actually, because most of us are retired and we get these notifications on our cell phones, which we carry around with us all the time. I typically will get these answered within a couple of hours. If you have a question and you'd rather not, go through the Maven platform, could you give them my email? Well, I'll give you my email. It's PKAPLOWI at Children's National, all one word, .org. Kaplowitz at childrensnational.org. And if you had a question that, uh, um, you thought about after the talk, just feel free to send me an email, or you can put it through as a Maven consult.
Great. Thank you so much. And then also, I wanted to let all of you know that Maven Project also has a mentoring and coaching program. This is one-on-one clinical mentoring and one-on-one leadership coaching. So if you would like to meet with a primary care physician volunteer to, practice your skill building or review cases, and just want to be able to have a good ear, somebody's who's available to you. You could set up a time, and sometimes people meet every other week for about an hour through our video platform. It's a confidential, customizable relationship so that you work with your mentor to determine what your goals are. They can also be a great ear to talk about time management, career development, work-life balance, and also with leadership coaching. If you're a site director or a chief medical officer, we also have leadership coaches for you to help support you in your career. And so I'm also going to go back to the Q&A, and they ask, I always ask specialists, what patients do they believe are being over-referred and what patients are not being referred that they wish were?
Ah, that's a good question. Over-referred is, certainly, I would say one of the over-referrals is short stature, where the height is just, right around the lower end of the normal range, and the child is growing normally. And, the parents are worried. Well, that's a situation where you could say, hey, your child is fine. You're not that tall yourself. But, a lot of these patients end up, being seen by endocrinologists who will usually tell them the same thing. So, mild short stature with normal growth is under referral is hard to say because, there's so much more tendency to over refer than to under refer. But, that's a toughie. My specialty is precocious puberty, and occasionally, we see a lot, even in my volunteer clinic, I see a lot of patients with a little bit of breast development, but a little bit of pubic, or a little bit of pubic hair. But every so often, we see a patient who's already started to have their periods. And if, they're a 8 or 9 year old girl who's having periods, well, you can bet that the breast development has been going on for quite a while, and either the child, the parents didn't bring the child in for their well child checkup, or they ignored it. So, under referral of rapidly progressive breast development is a problem, but not all that common. Well, anyway, thank you for your great questions. I enjoyed
Great, Paul.
talking.
There's actually a couple more, so we're glad we're inspiring more discussion. The next is if a patient has an episode of palpitations and fear and tremor episode, is this an endocrinology problem?
Well, it depends. Certainly, you've got to look for other signs of, that might suggest an overactive thyroid, such as a goiter, feeling hot when others are feeling comfortable, hyperactivity. But palpitations by themselves probably is more likely to get help from cardiologists. But certainly, you've got to look for other things that might suggest that it's a thyroid issue.
Great. And there's some follow-up to that question. The patient with an anxiety episode and palpitations and tremor and chest pain, but the blood pressure was normal. Do we need to worry about pheochromocytoma? And the thyroid is normal.
Yeah, how high with the pheochromocytoma, I've, rarely been involved in those cases, and they're extremely rare, but you can certainly get flushing, but the blood pressure is very high. So, did they mention what the blood pressure was in this?
The blood pressure was normal.
Yeah, if the blood pressure is normal, I wouldn't embark on a pheochromocytoma workup. So
Okay.
that's a tough case, but unlikely to be endocrine.
Okay. Great. Wonderful. Dr. Kaplowitz, thank you so much again. This was a great talk, a great discussion. Thanks to everybody listening in. You were a great audience. And I just wanted to give a big shout out to all of you that are working in clinics caring for underserved patients. You guys do amazing work. You work so hard to take care of the patients. They're really lucky to have you. So I wanted to wish you all a great rest of your week, and we look forward to seeing you at future MAVEN Project events. Take care, everyone.
Thanks, Jill, for moderating.